It's so nice seeing everyone today. It's like old home week in this room. But I'm going to reinforce a little of what Stuart was going to say. Let me tell you how we got to know Stuart. Some of you, of course, know Stuart. But I reached out to him last winter, I guess, because I was rereading Paul, the future, and Sarah in the crowd, the future of the nursing report. From RWJ's work and the Institute, then the Institute of Medicine, and I saw that Stuart was involved with that report and said to myself and to others, well, why don't we have a future of social work report? So Stuart has graciously really joined in on the bandwagon with us and sat down with us for many hours to think out how to come up with a report like that and the importance of social determinants. And he's a great guy, and I'm sorry he can't be here today, particularly because we made this date around him, right, Gene? Made Gene have a headache. So this is a great reinforcement for the distinguished Daryl Wheeler. Don't you think, Daryl? More than 60 million Americans experience devastating 1-2 punches to their health. They have inadequate access to basic health care while also enduring the effects of discrimination, poverty, and dangerous environments that accelerate high rates of illness. So I think your point was so well taken in terms of, has this ever been about Obamacare or has this been about race? So kudos for you. This is an interesting juncture in our world. I mean, all weekend long, all you had to do was listen. I swore to myself I wasn't going to listen to the news, but I don't know. I got caught this weekend for some reason. And, you know, what a time between the aging of the boomers, a new administration that is trying to repeal. I think they're trying to resist, repeal, and ultimately just rename. And, you know, maybe that's all that will happen, which will be good. Obama even said that this weekend. Just name it, Trump. But just name it, Ryan. I don't care what you do. It was really funny. And we have increasing rates of chronic conditions we saw. And it's making it harder for people to improve their health. And when we look at the triple aim that Don Berwick laid out and whatnot, it's just, there's an incredible challenge. And one of the areas that we've been working in is to, you know, they said in the beginning some of the high Medicare expenses had to do with readmissions to hospitals. And we've had a lot of focus on that at Rush. So I want to kind of walk us through that today. Look at what slide I had in here. This was not planned, but we all must be into it. I'm not going to dwell on it, but I guess what I'd like to see changed is I'd like the light box to be medical care. And then I'd like it, because to me, the red box or umbrella should be health care, which encompasses both medical and social. So that's how I would try to aim. We should all try to aim to change this unless people have a better idea. But we know our situation that we haven't been putting much into the social side. So it's an interesting time. We're dealing still with this acute episodic care syndrome that we're invested in. And we're trying to move from that, but it's still there. It's still there's still a little bit more about volume than value out there, focusing on putting heads in those beds in a hospital like a hotel. And it's a stressful setting. There's less opportunity for education in an acute world. Follow-up is often lost in translation. More and more people, particularly older adults or Medicare recipients, are coming in under an observation status and unfortunately ending up in a nursing home and not even able to pay for that nursing home because they didn't really have a real hospitalization. So it's tough times in the acute world. It is inefficient and ineffective. Then we're dealing with the ambulatory side of healthcare, which is all you do is talk to a primary care physician and they just read you and they just start to cry practically. They feel so pressured, there's so much more on their plate, there's so many more screening things they have to do, they have less time. And as a result, I think there's diminished quality in what's happening, little time to address the more functional social needs. And there's a lot of biases that get in the way and less time for discussion to discuss them. And they know, and I'll show you a study in a few minutes, that they know that this is happening. Social determinants, you know them well, conditions in which people are born, grow, live, work, and age. I don't believe healthcare or medical care has really addressed these issues or acknowledged them until recently. It feels like everybody's talking about social determinants all of a sudden. And this is positive for us as social workers and a little negative. And you can understand why. It's like these are issues we've known. This is part of our bread and butter. But now all of a sudden, I went to the American Geriatric Society meeting last May, bunch of geriatric physicians, and somebody said, "How was the meeting?" And I said, "Well, I think the geriatricians have discovered social issues." And even geriatricians hadn't discovered social issues until then. So it was really interesting, right, Marilyn? You work with a bunch of them, and you were there. And so it's an interesting time. But it's also, I don't mean it's threatening, but just a little that we have to be attuned to what's going on and try to figure out how we fit into that. So we know that social factors are having unbelievable outcomes in terms of poor self-management. And self-management is hot because a lot of what came up with the value-based purchasing is the physician, the providers, helping people achieve their health goals in new and different ways. That's why there's much more talk about motivational interviewing, those sorts of things. We know that housing and transportation issues increase healthcare costs and utilization. I had a fascinating meeting 2 weeks ago with Blue Cross Blue Shield. They are here nationally. Right over there, we'll show you the building if you want to see it. How many floors did they add on at one time? Like 12 they added on to the building, which is kind of unheard of here in Chicago. But they are interested. They came to meet with us at Rush. Why? Because they're interested in transportation. Because they know transportation is critical to get people back to the hospital after they've been discharged to make sure they follow up with their docs. And a lot of people can't afford to get back to the hospital for lots of different reasons. It's expensive, they're not feeling well, et cetera. So the Blues sat down with us because they're working on the ROI for transportation. So they're working on the return on investment. So they will start to pay for transportation based on what they find out. And they were so proud of themselves. And actually, you know who was leading the meeting? Their new VP of social determinants in an insurance company. How do you like that? So it's an interesting time. So we know about income and education and et cetera has an impact on expectancy, life expectancy. One of our colleagues at Rush wrote a book, David Ansel. He's written a couple books. He's a very thoughtful physician and public health person. But he has this chart that I want to add soon that talks about if you're born right here in Chicago, your life expectancy is 89 right now in this area of Chicago. If you go west, one L stop, the next L stop, the next L, you go down to the point right before Oak Park, which is a nicer suburb. The last stop before Oak Park, I think you're at 70 years old or 69. Unbelievable. And then you get to Oak Park and you're back up to 89. So what more startling than that in terms of what Daryl's point was before? So it's, again, a very interesting time. We know the social determinants piece inside and out, and the payment and delivery system reforms are critical. There are all these things that are being churned up, and we don't know what the future holds, but I think there is a little shift to be looking at food, housing, transportation as medicine. So that's a plus. That's a plus. There is an accountable health communities piece that came out of CMS, and people have been monitoring, and I'm sure Caroline has, right? And there's been a lot of criticism about this next innovation grant because it nods to the importance of social services in a way that nothing else has. Very directly, hospitals and social service agencies have to come together to address and screen for social determinants. Well, so it's really theoretically a wonderful concept. Practically, there's no money in that grant when it does get funded for the social service side. And as Linda said, in our state, there are barely social services hanging by a thread. Even when they start to build for Medicaid, we hope they'll come back. But right now, you can't, to think that all of us have hoped that more would come out of Medicare, Medicaid dollars to go to social services, but in this grant, again, theoretically it says one thing, and practically it's not necessarily going to sustain the social service component of it. But we still look and hope, as we should. And a lot of this, again, is try to reduce the acute care utilization that costs so much, and the post-acute, which people are beginning to recognize, and there's room for social work in both of those areas. So some of the Medicare payment innovations, all of a sudden, as of last week, there are some codes that many of us have been hoping for a million years. We've had a chronic care management code of the last year or two that some people are utilizing. We've had a transitional care management code, but now they've gone up a little in terms of payment, and now there's a new added behavioral health integration code. The problem with most of these codes, and Joel and I can attest, because there's a health and behavior code he and I have been fighting for how many years? To get social workers paid? A long time. We're getting a grade together. I just color mine. But right, Joel? But it's a really tough time because so often social workers cannot drop these codes themselves. It has to go through the physician. Even nurses are, many NPs, physician assistants, but not social workers in many cases. So this is kind of a dangerous situation. Payment to show that social work involvement is going to make a difference on reducing that total cost of care. So it's a critical time, but we may not be able to do it on our own. We have to do it within the context of the team, because very often it's parts of the team that may be able to get the revenue back to us to make sure we can staff the social work side of what needs to be staffed. Does that make sense? And some of that may be the social service organization. I'm not suggesting all hospitals should do what Rush did, which was build the social service component, but they should actually buy it from the social service world, because I think it will keep us afloat in a different way. So again, the accountable health communities, as I just mentioned. Well, the whole idea of MACRA, is it here to stay? Well, this was pretty bipartisan, and it really does address a number of issues around reimbursement on a composite score. They're looking for people to achieve higher levels of value and practice and quality. And there's a lot more about care coordination in there, and care planning and prevention and thinking about that. So we're hoping that through MACRA there'll be that will stick. When we looked at the patient-centered medical home regs when they first came out, we saw that there was a lot there about care coordination, but nothing truly about social work. But we were able, at Rush at least, to go to the practices that were going to get that designation for patient-centered medical homes and say to them, hey, we can help you achieve these outcomes that you need to achieve in order to gain your accreditation. And we literally gave them a chart that showed their different outcomes and how we could do it, and a marriage was made that way. So those are the kinds of things that we have to get creative with. And I think there's going to be a lot more transparency in our system, particularly around patients' involvement, decision-making, all things that are so closely related to what we do. So let's talk a little bit about this whole reducing hospitalization thing. It was funny, there were models out there, I'm sure many of you have heard of Eric Coleman, Mary Naylor. They were doing these transitional care models before reducing 30-day readmissions was even a big deal, because they believed, rightfully so, that when people leave the hospital after shorter stays and leaving, sicker and quicker, if you will, that people were cycling back prematurely very often, or unnecessarily, because their home situations where they transitioned to did not have the right setup for them to be there safely, comfortably, and in a long term. So they both developed transitional care models that are very successful. And we were beginning to notice that in a pilot study at Rush, we started looking and noticing that the psychosocial components were being missed, and those are the psychosocial and environmental components were the reason we were seeing a lot of people returning to Rush. Very little family support, very little resources at home, that sort of thing. Not being able to get back to their doctor's appointments, housing issues. So those were the kinds of things that we noticed. And there is a lot of attention right now on the whole notion of the emergency room. And is the emergency room a gatekeeper or a welcoming wagon to most hospitalizations? So I think in many good systems, you'll see much more involvement of social workers in emergency rooms right now doing social work type things. I have to be honest, at Rush, a year ago, you know what the social workers were doing? They were making sure that the people who were waiting were not dissatisfied to give us, so we wouldn't get bad points. So they were doing customer service rather than social work. So thank God we've moved that over, and we're going to see what happens, because as many of you know who are affiliated with hospitals, people end up in emergency rooms for a variety of reasons. And many have to do with just, not just, I don't mean to minimize, but needing a meal, needing a bed for a little while. And then how do we think about that from the social aspect? Is there a way to get around that? And those Housing First programs that have happened in New York and Colleen mentioned are phenomenal. So someone shows up in the emergency room, they're housing insecure, they call one of those Housing First programs, and it's not just about the dwelling that the person receives. They receive wraparound care management as well. And that's the piece that helps them stay safe in an environment that's better for them than keeping recycling to the emergency room. So I think we'll see a lot more of those programs and that partnership with social service agencies as a result. So we did develop a program, and I'll get into that in a second. But if you think about the press of the acutely ill patient, it's difficult for even the most motivated and elegantly trained providers to assure that patients receive the systematic assessments, preventive interventions, education, psychosocial support, and follow-up that they need. So even when systems are trying, sometimes this is not happening. And oftentimes it's not happening, believe it or not. So we try to look a little more deeper of why this is happening, and a great study that came from RWJ in 2011 was Healthcare's Blind Side. And what was so interesting about this is that the primary care physicians know people are coming to them with social needs as well, but many of them don't feel confident to address those. And part of that is they don't want to open a Pandora's box. They want to open up problems that they then can't solve. Understandably, there's nothing worse than that when you have a problem in front of you can't do anything about. And if 85% feel social needs directly contribute to poor health, and that if they had the ability to write a prescription for a social worker or someone to address those social determinants, 1 out of 7 prescriptions would be written to a social work type or someone to address those social care needs. So it's a very interesting point for us to take home, and how do we work with that? And how do we work as part of that team? When we know primary care physicians and providers are really drowning out there, how can we become part of that solution would be the answer that we'd like to figure out. And then it's all about teams. There's a lot of attention to teams, and there's evidence around team care. Yet, there's evidence around teams, but if you ask someone who really always uses a social worker on that team, why do you use a social worker? If you had to get one person off your team for cost reductions, how would you be able to save the social worker? And very often the answer, they look shocked by what we're saying or asking, because they don't know the answer to that question. So who asked about research? Was it you, Charles? To me, there's a lot of research being done in our field, and everyone in the room is a leader in that. What I think is often missing is health service research, or social work service research, if you will, to very much make that business case or that ROI more clearly for us to be that person there. There are so many times I'm on a phone call lately, and this gets to Colleen's point as well, where people say, well, Robyn, what's the difference between a social worker, an MSW, and a community health worker? And no one would say that about a physician, right? No one would say, do you really need a physician on this case? But I hear it all the time. Do you really need a social worker on this team? Can't someone else do this? A volunteer from the church? You name it. I mean, it's really, that's where we need to work with the research piece to show, no, there's a difference between that community health worker. And there's nothing wrong. Those community health workers are doing incredible work, not to put down any other field in the process of lifting ours up. That's not going to get us anywhere, making this a guild issue. But we need to be able to articulate what is different in a way that is clear and people can understand. So I think we're moving much more toward interdisciplinary care. Health education, improve patient experience, the mental health into the primary care, the integration, and now we have some billing codes to even bill for that. And it's an interesting time. So why should we be involved in this? Well, I think I've said a lot of that. We are the people that understand both the community very often and the hospital systems. So when you're thinking about reducing acute care stays, which I'm supposed to be talking about today, there's people that can really cut across. I call many of our staff bilingual, bicultural, because they speak both the community language, which is very different, and the hospital language. And you have to be able to cross that somehow in order to be accepted in each environment and be able to work together to keep people home safely and with the services they need. So it's an interesting time. It's a very person and family-centered time. And we have a history for advocating for marginalized populations, and this is the time to do that because most people falling through the cracks are more of the marginalized folks. So again, how do we define our contributions? What do we bring? You know this better than I. We understand stages of change, cultural humility, psychotherapeutic techniques when needed, motivational interviewing, all of that. I mean, that's a new term the last 5 years, but we've known that term for many years. And we just didn't frame it in a kind of a way that's picked up and people have run with it. Again, sometimes our work is undefined, and it then, as a result, lacks the provider and payer buy-in. So again, that need to sort that out a bit more to really show the value of our impact. So let me just talk to you about a couple of our projects at Rush and then some other things going on nationally to kind of build this movement toward evidence in a way that I think will move us forward in so much of what we're doing in a policy way, I hope. I mean, you can't look at practice without the research and evidence build, because the evidence build, even though it doesn't take much evidence to influence policy, I think it takes a little. So let me tell you about our Bridge program. It really did start as a reaction to Eric Coleman and Mary Naylor's programs who were using nurses. They were not focusing on social factors as much, and basically I approached them and said, would you guys mind if we played out this transitional care notion with social workers? And they said, go forth. And it's funny, they've both included social workers now in their transitional care models. So it's great. I'd like to believe they either, we influenced that or there was an awakening. Either way, it's great. So we get involved with people as they're about ready to leave the hospital. And we do that through some sort of a risk stratification attempt. So we know the people that we've tried to hone in on, the people who have the greatest potential to readmit unnecessarily. So we've done that, and we have a pre and a post involvement. We get very involved in the electronic medical record, getting to know who this person is medically. Then we try to get to know who this person is personally, and sometimes we ask questions of people lying in their bed that have never been asked of them, and they're usually very intrigued and say things like, oh, it sounds like you'd like to get to know who I am. And yeah, because no one else has had the time to. So then we do that, and we tell them we're going to be following up. We anticipate what they're going to need at home. We try very hard not to step on the discharge planner's toes. We work with them and really make it clear that we're going to pick up where they leave off. Because if we had ouched them out, we would have really been in trouble. So post-discharge, we usually are involved with people for 30 days. We facilitate their connection to community-based organizations or CBOs. Home health care, we literally sit down with the home health agents who we agencies we've referred people to on a weekly basis to make sure they're getting the care that they were promised and trying to keep them at home as long as possible. And then we really try to engage patients. So often we call people after they've left the hospital and talk about the importance of getting back to see their physician in 7 days, 14 days. It's a lot of what the rules say and the evidence. And people say, well, why do I need to see my physician? I just saw her. And we have to, a lot of what we do is health literacy, health education, because people just don't understand. They don't read the journals, they don't read the evidence. So how do we help them be part of their health care and not just defer to others to do that? So we're very much trying to bring together all the components of what we're talking about: the client, the caregiver, the hospital, the community agencies, and this bridge care coordinator is always an MSW. We've replicated in 65 sites across the country, and one thing we've stood by is we believe these should be MSWs. And we've been challenged, and some places in rural areas don't have MSWs, and we've worked with them too. We haven't thrown them out by any means, but we very clearly state the skill set that's needed is that of an MSW level. Some recent research has shown great success for us in terms of reducing 30-day readmissions. This was reported in the Journal of the American Geriatric Society, that in all areas we were really reducing readmissions. In some of our prior work, we have shown a reduction in readmissions, an increase in getting back to their doctor, a reduction on caregiver burden and stress. So we've seen some good results with this model, and it has been acknowledged as an evidence-based model nationally, and we're pretty proud of it. Caroline Ryan, who's over here, started it with us, remember? And she was from a community agency, because we believed at Rush we needed to do the same thing community agencies, and those are most of the places we've trained to do this model, have to be involved, because they can then approach the hospital and say, we are your 30-day reduction solution. And they're usually not embraced, but they keep trying. So we also now have used this in more of a superutilizer role. You've heard that horrible term, frequent flyers. We don't use that term. I'm just trying to point it out that that's what people talk about, and we've made great effects on that whole superutilizer. We know that there's probably just a few people that create those high readmission rates for hospitals. So if we hone in on those few people, and they literally become part of a couple social workers' registry, if you will, that they're working with these people all the time on their caseloads to make sure that they're not coming back, things are going well, they're getting to their physician, et cetera. And then, so the partnerships, as I talked about, 27 of the 65 sites that we've trained in Bridge, our CBOs are mostly the Aging Network. So this is a great time, because the Aging Network is also really looking at business acumen, and in a very wise way, supported by many foundations, and just encouraging them to be able to work with the hospital world, the payer world, the managed care world, and be able to say, we can come work with you, please purchase us rather than build your own. And again, it's a great time and to do that, and also to work with the nursing homes where people are going to make sure they're getting out of those nursing homes if they don't need to be there too. So it's a critical role for us. We also recognize that it wasn't enough that we were just concerned about readmissions, but we should be concerned about admissions too. So we looked at outpatient care and tried to wrap around that care and say, like I was explaining with the patient-centered medical home, this is what we can do for you. We know you're getting points or you're getting points taken away from you when your patients don't adhere to their care plan. I hate that term in here, but don't meet their own goals. We can help you with that. We can help people think about how best to meet their goals and what's getting in the way of that. And as a result, we've been able to wrap around primary care. We've been respected. I mean, 12 years ago at Rush, people didn't know what social workers did. There was not even a term social worker. The discharge planners who happened to be MSWs were called what the department was called, which was utilization review. So when I came in and I started talking about social work, in mental health settings, in the more medical side, people were shocked because they didn't even know social workers could be mental health providers. It was a little shocking. It was shocking to me, but I think now, 12 years later, we're not only known for what we do, but people are demanding our services. We actually don't have enough to meet the demand because we haven't actually figured out the bottom line of the finances. In certain areas, for example, our neurology department pays for 3 of our social workers. But they brought in a new administrator 2 weeks ago. I met with him the first week he was there. And he said, "What am I getting for this? What am I getting?" And, I needed to be like this. And I don't think I was. But I went back and I did my homework a little better because the prior administrator adored us, and I just assumed this guy would. I was wrong, so I regrouped, came back with numbers, we're working on it now, again, showing that business case to him. So we've developed this ambulatory integration of medical and social, calling it AIMS, and we're replicating in places like Maryland and other places in Illinois, and hopefully hope to grow this. And we're basically working with the team, and we have some promising findings. Vicki Rizzo, who would have been here today if she didn't need to be in New Orleans today, she needed to start the Leadership Institute. She and Janine Rowe, another colleague, we have a Commonwealth Fund grant to really evaluate the AIMS model. But in the pilot data, we were showing some promising impact that just by the social worker touching this patient in and around their primary care experience, we were making a difference in terms of that 30-day readmission reduction, hospital admission reduction, emergency department reduction. So we're really excited, and that's why Commonwealth wanted to support us to delve deeper and to figure out, is this true? And so far, we hope it is. We're also growing with the Medicaid managed care world, and we are part of a Medicaid accountable care organization in Illinois, in Chicagoland, called County Care with our Cook County Hospital. And what we did differently here is we have a care manager who's an RN, one that's a social worker, and then we have a patient navigator who's not a licensed type person. But we're trying to figure out how the social worker is successful in this triad approach and what they bring to the triad differently than the rest of the team. And we're trying to figure out who potentially should work with which patient. Not all patients or members, in this case, need all 3 of these folks. So how do we kind of look at them in a way, and we're looking at this medical complexity and social complexity in this kind of piece, and we're trying to do some research around this to show who could benefit from the social worker versus the nurse versus maybe the navigator. And then we're probably going to bring in the primary care doc at some point too. So we don't leave them, we don't mean to leave them out, but they're really excited about this, that we figured this out. Because this has implications for inpatient social work too, and discharge planning, particularly models where there are nurses and social workers in terms of who does what and who does what differently or has a greater impact. So we're excited about that. And then other significant social work efforts that we're watching, one in the room, the VA, well, Laura should talk about that herself, but Mount Sinai, who many of us met with in a meeting around the Grand Challenges a few weeks ago, they're doing incredible work with the PACT, the Preventable Admission Care Team, and I believe that was a CMMI grant as well. And it's a 4-week social work intervention pre and post to identify and address issues driving readmissions. And that 40% reductions in admissions and 40% reductions in ED visits have occurred, and a greater increase in PCP follow-up. They also have a mobile acute care team that's showing some great impact too, because not everyone can get to the hospital, so they're going out into the community, as should be in many cases. And then the VA, of course the VA, we look to everything for the great success that they're doing, and the biggest employers of social workers in the country and world. But they're really doing all different types of things, but there's some great care management programs. And then the PACT program, which is a wonderful program, maybe you can talk about it later, where social workers play a leadership role in linking VA care with non-VA hospitals and services. So there's a lot to look at. Again, how do we bring it all together? How do we do that in a way and I think we'll do some of that today, of course, to scale up and to spread and to build what we know is successful work and get that ROI in terms of care coordination. So the challenges I've said are the long-term resources. They're just not there right now, but I think with all these different things coming together, we're really at a good point if we can pull it all together. Again, how to improve our impact or prove our impact amidst the continuous quality improvement efforts. You know, in many ways, I wish Berwick in his triple aim, and sometimes it's a quadruple aim, he cares about providers now. I wish he'd do another aim around the social care aspect, because if all of it is about improving patient care, maybe there would be a way to put the social piece in there. So it is an unpredictable future, but I think we are geared up to make a difference, and we're excited about some of the reimbursement. We're excited about the focus on family caregiving lately in the IOM report and other things. Well, who better to work with families, stressed families, caregivers who are getting lost and overwhelmed than social workers. We're excited about some of the vital direction papers in health and healthcare that some of you in the room have been involved with, the grand challenges aspect. And we are really waiting, hopefully soon, to hear about our National Academy's report and how it will move forward. And it's getting a lot of attention and unbelievable support from the National Academy and from many of you in this room. So let's hope, cross our fingers, and continue the momentum and continue to think in interprofessional ways, care models that involve us, care coordination, and how better to understand our contributions. So thank you. And questions, thoughts?
First we have to say.
Colleen.
Hi, Robyn. You had mentioned, by the way, wonderful talk.
Thank you.
You had mentioned the bridge model in relation to skilled nursing facilities.
Yeah.
Could you speak a little bit more about application of that? And do you have any outcomes and or articles out there that one might be able to look at?
Bon, you want to take that one?
Is this on? Hi, everyone. I'm Bonnie Ewald. I work with Robyn at Rush, and I've worked on the Bridge project for a few years. We don't have any articles about working with SNFs, but Aging Care Connections is a care coordination unit, which is one level under AAA's here in Illinois. They've been working with a couple of SNFs with contracts now, reimbursement contracts, which is really great, for a couple of years to initially, they were focusing on the transition between the hospital and the SNF just to help facilitate communication and facilitate communication with the PCP. But now that SNFs are going to be on the hook, I think, starting 2018 for readmissions, but I don't know the dates for sure.
18 is only a year away now.
Yeah, we're already in 2017. They do have contracts to help transition folks from the SNF back home to the community. I think basically where they're looking is just trying to gather pilot data on what their impact is. So we don't have anything published, but.
Hi, Robyn. Thank you so much. I really think that you've hit on so many core components, and one of piece was the interprofessional team. And you have published a lot in this area, but also the Reeves study that has looked at patient outcome related to the interprofessional team. How can we best take that concept of the interprofessional team and the work that you're seeing with Rush as well as Mount Sinai, who Fordham has worked with as well, how can we take that and really educate our students in social work to really be better social workers in the interprofessional team and in the work that they are, responsible to accomplish?
Absolutely. Great question. And I think that that's critical for all of us. And teams work when there's empathy, understanding, being able to stand in each other's shoes, that kind of thing. And One of the things is social workers need to open their mouths. I hate to say it, but I sit in too many situations where the social worker sits sheepishly in the corner and doesn't feel like they have anything to contribute because the docs are talking or the nurses are talking and it sounds too medical for them. And, you know, I'm not suggesting every social worker needs to know every diagnosis, but they need to be able to jump in on the stuff that they do know. And it's interesting, Marilyn is working with the hotspotting program out of Camden Coalition, and some of us have been working with them lately. And they said to us recently that the strongest people on their team are the social work students because they're using students. So that was great to hear. I'm not saying that everyone's like that, but you can't imagine how much I have to push our staff at times to say, you have something to offer, say it. Mm-hmm. You can talk about this person in a care round kind of thing that's about ready to leave the hospital as to the red flags you see as why they might come back to the hospital. So say it. So I think that's part of it. Marilyn, anything, you're the team guru in the room.
I would not go that far. But I guess one of the things that I'm thinking about, and this takes me back. This takes me back to my days as one of the geriatric interdisciplinary team training sites at the University of Minnesota, when we had a geriatrics program that, of course, was dismantled because we weren't making money and politics played out. But I think one of the things, I just flashed back to the very beginning with, I saw you citing Chad Bolt. When he hired me to be the lead social worker in that clinic, we started out with the social worker introducing every patient. I mean, even if we were doing team huddles in the room, the social context was more important. So it's inserting yourself when there's really something vital that you have to contribute, but it is also being visible in that kind of a role when you're parading through all kinds of students who are learning from multiple disciplines, that the social worker is setting the stage for addressing the other issues related to this particular person's care.
Perfect. A protocol that would emphasize that role would be great. Ellen.
Hi, I'm Eleanor Shansky, and I'm the inaugural chair of a nursing department that's in the Suzanne Dworak Peck, Marilyn makes me always say the name now, the Suzanne Dworak Peck School of Social Work.
If I gave that much money, I wanted
yes.
to say my name too.
And Suzanne's a great person too. She's a social worker, so we're excited about that. Anyway, I feel like I could talk for hours, but I want to preface this by saying first of all, I'm really honored to be part of this group. And I come to this group with, in a way, a dual identity. I started out my career in social work and went to UC Berkeley and then went into nursing, and now I'm working in social work again. And I feel so strongly that we have an unprecedented opportunity to turn healthcare on its head, and that we can do this by really joining forces. I know, Robyn, you started out mentioning the Future of Nursing report, and yes, that was great for nursing, and we're proud of that. But we in nursing still deal with so many of these same issues that social work does. We still can't work to our scope of practice in many states, including California, which is supposed to be so progressive. There's so many things that where we together at the intersection of nursing and social work can work. So when you talk about interprofessional work and also hopefully this proposal through the National Academies of Medicine will get accepted. And I think that it's an opportunity to talk about the key central role that social work has in collaboration, again, with nursing, really focused on social determinants of health. But anyway, I have a lot more to say. I don't want to take, but this is just really inspiring to think about what
we're
we
glad
can
you're
do.
here.
We have time for one more question, and then we'll start.
Right here. Thank you very much. Robyn, wonderful. That makes the meeting in that library way back when.
God, when was that?
I know. You were still in your MSW program. Okay. I will at the break. I do agree that social workers need to open their mouths, but when they open their mouths, they need to have something to say and stop. That's really important.
Perfect,
That's really
you're right.
important.
We're a little too processy, Tom.
Yes, and number two is because we have, Darla, you know I was going to say this, and I'd like your thinking on this. It's important, and this may go to Charles's point. One of the reasons we're under threat for our ROI and our business argument is because in my perception, I don't think there's a seamless relationship between the research, what gets from the research put into the training program, and then what becomes required as ongoing practice development. Because when you put 12 social workers in the room, you can get 12 different outcomes for the same supposed thing, and I think that dilutes and weakens our position. And without that integration between the research, the educational requirements, and the ongoing training, I think we'll always be in this position of an identity crisis.
Yeah, great. I can't say anything to it, although I just have to reinforce the importance of what you said, the ongoing training or the continuing education. The people who have been out a long time like me, we have to bring them back to talk about things like evidence, which they didn't hear much about when they were in school. They should be reading about it now, but they may not be. Thank you.